Good morning, good Monday morning. Welcome to all of our viewers and participants in this webinar on venous thromboembolism prevention, the nurse's perspective. I am excited to be here with our presenters and with our co-moderator, Arthur Allen, and we're looking forward to sharing with you some great information that Johns Hopkins University folks have done on VTE prevention. Next slide, please. So here are our presenters today. We have Dr. Elliott Haut. I'm going to probably mispronounce that. I'm terrible at pronouncing names. Dr. Elliott Haut, he is the Vice Chair of Quality, Safety, and Service, the Associate Professor of Surgery, Anesthesia, and Critical Care Medicine, Emergency Medicine, Health Policy, and Management at Johns Hopkins Medicine. We also have Dauryne Shaffer. She is the nurse educator in the Department of Surgery. She's the lead educator for the Johns Hopkins Medicine VTE Collaborative. I have my co-moderator, Arthur Allen, who's a pharmacist and the Anticoagulation Program Manager at the VA Salt Lake City Healthcare System, and myself, Andrea Van Beek. I am an anticoagulation clinic nurse practitioner at Visalia Medical Clinic, Kauai Health Medical Group. Next slide, please. These are our disclosures for your review. Next slide. Some of this work has been funded by various institutes, as well as the Agency for Healthcare Research and Quality, National Heart, Lung, and Blood Institute, and the Patient-Centered Outcomes Research Institute. Next slide. Additional disclosure that Dr. Haut is a member of the Board of Directors of the National Blood Clot Alliance. He's an unpaid volunteer. Next slide. And now I'm going to hand it off to Elliott, and he's going to walk us through what Johns Hopkins has done in the space of VTE. Take it away.
Hey, good morning, everybody. Thanks for having us here today. So the way we have this set up is I'm going to get us started. Dauryne's going to take over for the middle section, and I'm going to close out. There are quite a few slides, but I promise I will get through them. So we're going to talk about venous thromboembolism today. And, you know, there's this question of why should we focus on VTE? And the answer is VTE is very common. It affects, you know, up to 600,000 Americans every year. That number might be even higher. This is from data that's, you know, over 10 years old now from the Surgeon General's call to action to prevent VTE. We also know VTE is quite deadly. It kills 100,000 Americans every year, more than breast cancer, motor vehicle collisions, and AIDS all combined. And I just showed you that report from the Surgeon General, and this is a picture of our team with the Surgeon General who visited us literally the year after that report came out. And the reason I show this is to say that much of the team is exactly the same that has been working on this work for, you know, literally 15 years together. Same nurse team, same physicians, same pharmacists, same informatics, et cetera. We've been working on this problem for a long, long time. So we know there are many risk factors for venous thromboembolism. You know, these are ones that are associated with VTE in the hospital. I'm not going to sit and read the list, but I am going to just tell you that this applies to patients with medical diseases, surgical diseases, obstetrics, oncology, lots of different patient populations. VTE is also very expensive. You know, the quick summary of this slide is it costs the US potentially $10 billion every year, VTE. It's also mostly preventable, and that's what we're talking about today. So we know that not all events are preventable. People who've been working in the space for a long time remember when people tried to say this was a never event. It's really not. Not all events are preventable. You know, even in patients getting best practice prophylaxis, some of these events will sneak through. This is an example of some data we put together and published in JAMA about orthopedic joint replacement patients. Even in those patients, highly selected, carefully screened in studies, symptomatic VTE rate is up to 2.5%. And in this paper, we reminded everybody that prophylactic regimens do not prevent all VTE events. there's tons of lists of all these different organizations that put out evidence-based guidelines. Some are very general, American College of Chest Physicians or ASH. Others are much more specific. For example, EAST, I'm a trauma surgeon. EAST is a specific one for trauma or OB, etc. But even knowing that there's all these guidelines of what we should be doing, we as a medical community don't do well. This is some older data that showed that of patients with deep vein thrombosis, only 40% had received appropriate prophylaxis before their event. We were not doing well. And if you think that's just a US-based problem, that would not be correct. This is data from the ENDORSE study, so 70,000 patients, 350 hospitals in 30 countries. And look how poorly we did. I'm always happy to say that the surgical patients got better care than medical patients, but it's still pretty bad. 60%, 40% of patients getting appropriate prophylaxis. It's just not okay. And almost 20 years ago now, the American Public Health Association told us that this disconnect between evidence and execution as it relates to DVT prevention is basically a public health crisis. AHRQ, Agency for Healthcare Research and Quality, has stated before that DVT prophylaxis is the #1 strategy to improve patient safety in hospitals. And when you look at this list of the top 10 strongly encouraged patient safety practices, interventions to improve prophylaxis for VTE makes the top 10 list. It's absolutely critical that we should be doing this to improve patient safety. This is actually based on data that we wrote and summarized in this brief review about all the types of interventions that can work to improve prophylaxis. So I'm going to briefly talk about some systems approaches that can help prophylaxis prescription in general. So we know that passive dissemination of guidelines doesn't really work. Handing out laminated cards or pieces of paper reminding people what to do is not great. What we really need is active strategies used together and combined to build systems for better care. So we wrote an editorial. This is a short, quick, easy read. It has no statistics or data, and it's really lessons we learned about how to improve prevention for VTE. This is back in the day when we had paper order sets. So we used to hand these out, and the residents or nurse practitioners, PAs, et cetera, would be writing orders, and this is what they would follow. It's very difficult, it's very complex, it's hard to read, but this is all we had. We then switched, and we're not the only place that's done this, to a mandatory risk assessment in our computerized order entry system. This doesn't sound new now, but at the time when we built it in 2007, it was, I say it was advanced at the time. And here's some old screenshots, and they look different now, and everyone has something that looks like this. But we had VTE prophylaxis within the general order set, a parent order set, for example, for whatever you were admitting a patient for. And it would take this complex algorithm that physicians don't love to look at and make it very easy. You know who loves to look at an algorithm just like this? Computer programmers. So what did they do? We gave this to them, and they programmed it and turned this complex flow diagram into a simple checklist. So now whoever's putting the orders clicks a few boxes. So they would click some risk factors. They would click some contraindications to pharmacologic prophylaxis, and up popped the answer of what they should do. And you know what? You can't do the rest of your orders unless you've done this risk stratification tool. So it really helps. Mandatory is the key word. So that computerized system that many people have now in different formats puts VT prevention right into the routine workflow. It's right there when we're doing our routine patient care. Rapid, accurate risk stratification. The evidence is at your fingertips, and we can update it as recommendations change. And I'm going to show you a little bit about performance monitoring and reporting. We're going to use the data of what people are clicking and doing to see how well we are doing as a medical community. These are some of the things we thought were some of our key successes. it really is a multidisciplinary team. You'll see later on, this is not just lip service. We really do have physicians, nurses, pharmacists, informatics, all working together. This is not just doctors doing this or pharmacists or nurses. It really is a team. Leadership buy-in. I mean, I was a very junior faculty and the dean of the medical school knew me by first name because of the VTE work that we were doing. Leadership cared. We collaborated with the service teams. We didn't just tell orthopedics what to do. We worked with them on what they should do. We were educating frontline providers, telling the interns, residents, PAs, bedside nurses. And then we measured some performance, and I'll show you what that looks like. So does all this work make a difference? It does. I'll briefly go through two quick papers we wrote. The first of which about our order set or our decision support tool was this one in Archives of Surgery, which is now JAMA Surgery. We did a single center, like I told you, this was a Johns Hopkins pre-post study. And this one photo or this one image really summarizes that whole project. So I'll walk you through it. On the left-hand side of the screen, you'll see 1 year's worth of data. This was hand-collected data, paper charts. We had an undergraduate student who went through and looked at every single paper chart. And at the time, we were giving appropriate prophylaxis to about 60% of our patients. After that red line was our intervention, and for 3 years, we were then able to pull the rest of the data automatically or directly from the electronic medical record. And you'll see that our prophylaxis went up to about 85%. VTE moved down or trended in the right direction, and we were able to significantly decrease preventable harm from VTE. And that preventable harm is patients are still going to potentially get some VTE events. They might slip through the cracks, like I said, but the preventable part is we've done the best we can. We've provided them with best practice prophylaxis. So that was trauma. This one's actually in medicine service. Similar idea, a pre-post study on internal medicine patients. It says trauma, but it is medicine. And here's the data on that outcomes or the outcomes from this study. So you'll see we were able to significantly decrease the total number of VT events. Went from 2.5 down to 0.7%. Statistically significant. And also preventable harm went down to 0. All those 7 patients who had events had been prescribed appropriate prophylaxis. So we're moving in the right direction. We're doing well. You'll see that's that preventable harm, 0. It is possible. It's a realistic goal. So my colleague, Mike Strife, and I went and collected this nice big award from the North American Thrombosis Forum for doing this work. We were cited by AHRQ as a leader in this with our collaborative translating evidence into practice and using decision support. We collected a nice big golf check from the CDC. We were doing well on prophylaxis, but we weren't perfect. Like I told you, we were up to 85, maybe 90%, not doing well as we were hoping for. So we continued that work. This is prevention prophylaxis prescription. So we decided we were going to harness the analytics. Now we have the data, it's in the electronic medical record, and we're going to do the best we can to provide the data to frontline people to use the data to improve their care. So what does that look like? We were going to start in the trauma service. I said, I'm willing to look at my data and compare to my partners. And there we are. Those dark bars in the middle are me and my trauma surgery partners. And we were all statistically the same. There's a little variation, but we're all middle of the pack. So why is that? Because we don't actually put in the orders. That gets done, at least on our service, by the residents. So that's where the variation is. The residents have to be the target. They're the ones who are driving or actually performing the care. About half of the residents were perfect. They gave the recommended prophylaxis every single time they went through the order set. That's our goal. But if you look at the other half of the residents, some were in the 70s and 60s and 50s, and there were 7 residents that never followed the recommendation. That might have only been a couple times, but you can see the huge variation at the resident level. So what did we do? We gave the data back to residents. So here's the resident data. The resident data shows that This is the pre-data. Overall, we're 87%, and each resident is one of these lines. And over just a quick few months, we were able to improve the residents' practice. They changed, they did a better job. This is some longer-term data on that same intervention. You can see it goes up and it's sustained over a year and a half. Okay, so we've done a good job. We've improved care. We're prescribing all these appropriate prophylaxis regimens for patients in the hospital. So now what? The next piece really has to do with missed doses of VTE prophylaxis, and that's what we're going to spend the rest of the time today on. We've always had this big assumption that we as physicians, and I talk to Dr. Strife about this all the time, you know, we write this order, we were making the residents do it, we're helping them to do it, we're making it easy. But just because that order gets placed, does that equal administration? You know, there are these three critical parts. We've talked about provider prescription, but the rest of today is going to be that a nurse has to actually administer that medication to a patient who accepts that dose. Don't forget, many of these are injectable medications, and that is another potential barrier. So you might be asking, you know, yourself or me, you know, who cares? What if people miss doses? There's now a robust series of papers on the impact of missed doses of VTE prophylaxis in hospitalized patients. I cite this as the first one that we know of. You know, this is a trauma and general surgery patient population. And the general takeaway message from this paper is a significant number of patients miss doses. Over 50% of the patients are missing at least one dose. And DVT rate is higher in patients who miss doses. So it shows us that it makes a difference. This is another paper we wrote. This looked at patients in our Maryland Hospital Acquired Conditions program. This is our pay for performance in the state of Maryland. It's a year's worth of data. About half the patients that had a VT event had perfect care, defect-free care, appropriate prescription, and got every single dose in the hospital. But you'll see this far bar at the right. About a third of the patients with events had missed doses of prophylaxis. This is associated with VT events. And there's lots and lots of data on that. You can find papers in colorectal surgery, other patient populations as well. So we wanted to know how common this was in our hospital. And it turns out at our hospital, and this is older data, this is the first paper we wrote on the topic. We looked at 100,000 doses on med-surg floors. 12% of doses were not administered. Just think of the number. That's 12,000 doses weren't administered. And patient refusal is the number one reason for that. And you'll see what we did to try to attack that. You might be wondering, especially if you're a pharmacist, well, maybe that's the same just because all medications are like that. And it's not. You don't even have to be able to read this slide to see that that big, huge bar, that's VTE prophylaxis. And all these other little bars are other medications. It's very, very, very different. And it's not just a problem at our big academic, you know, quaternary 1,000-bed hospital. This is a paper we wrote looking at data across our health system at 3 of the community hospitals in our system. Similar data. You know, 10, 12, 13% of doses are missed, and over 40% of patients are missing at least one dose. It really makes a difference. So with that, I'm going to change gears over to Dauryne. I'm going to mute my slide, mute myself.
Okay. So thank you, Elliott. And if you can go to the next slide. So Elliott's talked to you about the work that's been done with risk assessment with actual prescription of this medication. So that was addressed. But now we need to do a deeper dive into some of the other barriers that prevent a patient from actually receiving their best practice prophylaxis. So looking into that is we wanted to know what are some of those barriers. So a mixed method study that was both quantitative and qualitative was done, looking at observations of patients, doing a nursing survey, and then also meeting with focus groups of nurses, if you can advance the slide. So the question on one of the surveys that was really resonated with me is, I have the clinical knowledge and experience to determine if it's necessary to administer DVT or PE prophylaxis injections to patients. Now, across the board, medicine and surgery, it was about 80% agreed with that. And when you think about that, what's that doing? That's actually essentially turning an ordered medication into a PRN medication. Next slide, please. Now, the next aspect of this project was the qualitative. So is VTE prophylaxis optional? And this was not a blinded study. This was a pharmacist walking up to a nurse and saying, hey, I want to go with you while you're administering your VTE prophylaxis. And these are some of the comments that they heard. As I push harder for my patients to accept heparin, if they have like sickle cell as opposed to, say, pneumonia or something where they're just here for IV antibiotics. And also sometimes it's the middle of the night and it's the only medication I have to give to a patient. And I'm not going to wake them up just to give the VT prophylaxis. Now, I want you to think about this. Would you go to a patient with sepsis and say, yeah, I'm just not going to give you your antibiotic? You know, sepsis kills, but so does VTE. And next slide, please. And then there's the ambulation myth. You know, listening to nurses talking to their patients, we make clinical decision all the time as to whether a patient needs VTE prophylaxis every day based on how much the patient is ambulating. Or, hey, Mrs. R, it's time for your heparin dose. As long as we see you up high-fiving in the hallways, we can hold off for now. If ambulation is effective VTE prophylaxis and can replace VTE prophylaxis, I'm going to ask you, what's the dose? Next slide, please. The ambulation myth is busted. So we did a systematic review looking at all of the evidence to see, okay, is ambulation best practice for VTE and can it replace gold standard, which is pharmacologic practice? And what we found is there's no good data out there. You know, again, I ask you, if ambulation can replace VTE prophylaxis, what's the dose? And unfortunately, it's, you know, nurses will continue this myth. We've had providers, you know, physical therapists, clinical technicians, you know, if you're up walking around, you don't need your VTE prophylaxis, but there's no data to support that. Slide, please. So our first query project is we looked at this, preventing VTE thromboembolism. We want to empower the patients and enable patient-centered care. But to do that, we need to look at all of those aspects as Elliott had talked about. Slide, please. So our goals with this project is the patient-nurse communication. And in doing that, we need to impact the nurse's understanding, and we also need to impact patients' understanding. We want to empower patients to take an active role in their VTE preventative care. We're not here to bully patients. We want to make sure they're getting the best prophylaxis that they're willing to take. And we want to use that, do that using a real-time escalating alert. If you have a notification and you don't do an intervention until 3 hours later, that's a missed opportunity for a patient to get their appropriate VTE prophylaxis. And we don't know what's the most important dose. Is it the first dose that they get on admission, or is it the last dose as they're walking out the door? Slide, please. We utilized our key stakeholders. We asked patients and members of these national organizations such as CACP, National Blood Clot Alliance, the North American Thrombosis Forum, and we asked patients. We utilized our PFAC members, our Patient Family Advisory Council, to help us develop a lot of the educational and to tell us what they actually needed. Slide, please. The article, if you'd like to look up more specifics in regards to this, it's accessible on the Patient-Centered Outcomes Research Institute website under Research and Action. And also, next slide, please, is that nationally, at the time that we had done this, it was recognized that this is an important patient safety issue. And there was an article that was done in the Wall Street Journal specifically on the project. Next slide, please. So, we talked a bit about some of the barriers and nursing understanding the importance of VTE prophylaxis as one of them. So one of the questions that we needed to answer was, does nursing education actually improve VTE prophylaxis administration? So we did a clustered randomized style study, which when you're looking at nursing education is, think about the way that we usually get our education. It's that voice over PowerPoint, click, 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 and then do an assessment. So we wanted to see if we engage nurses more specifically with interactive and scenario-based, whether it would show that it's a better interaction, and whether there's better education retention, and whether, even more importantly, that it actually impacts delivery of the medication. So what we compared that static with is this scenario based. It's more interactive, looking from the nurse's perspective of different scenarios where a patient may refuse medications, and then will lead you into questions that you may have in regards to VTE prevention. Slide, please. So we did a clustered randomized trial, utilized 10 surgery, 11 medicine floors, and all of the nurses on the specific floors were assigned either to the static or the dynamic education. We administered a satisfaction survey, but more importantly, we looked at that primary outcome of dose administration. So not only did nurses like it, but did it actually impact practice? Slide, please. And what it showed was education works. Interactive education works better. Slide, please. So if you'd like to learn more or see the actual module, is you can access that through the Armstrong Institute for Patient Quality, Safety and Quality. So now we want to know, we've impacted the nursing aspect of this. So now what do patients really want? And the best way to find that out is to ask them. Okay, so we did an online survey. It was an iterative modified Delphi process, and it had surveys, feedbacks, and revisions. We also engaged patient and family members. So we recruited them via email, social media, and we had more than 400 respondents. And what we found was this is what they wanted. It was very interesting to me is patients want to speak to someone, definitely want to speak to someone, but a significant portion of them still want paper. Whether it's to share with family members, have it to read a little bit later. They're not feeling well enough to access some of their online content. They do want videos, which was not surprising, but wanted to talk to people, wanted a video, and wanted a paper. So they wanted that multiple options for getting their information. And then we asked them what they want to learn. And then how much are they willing to read? What is the preferred length of the video? So they spoke and we listened. Slide, please. We engaged with patients so much and had them review all of the developed content that 2 of our patients actually were co-authors of this study article that came out in regards to this project. Slide, please. So what do patients want? Next. We bundled what they asked us for. So the paper form, this was developed based on the input from our patients, was vetted with patients. We actually reviewed it with focus groups. We brought it down to the Northeast market. There's a market that's in the Hopkins general area, and we brought the different iterations of this and actually had the man or the person on the street read and review and gave us input. We made changes based on that input. They spoke and we listened. Next, please. We have it in multiple languages. The perception of patient-centered care. If you have a patient who has English as their second language, having it available in their native tongue actually engages patients to be able to share with family members, and that shared decision-making and empowering them to make decisions about their own health care. You can access that through the bit.ly here. So with our video, we were lucky enough to get an Oscar-winning documentary director who developed and filmed the video for us. The patients wanted about 10 minutes. They wanted to hear from physicians and nurses, but more importantly, they wanted to hear from patients who were talking about their own experiences with VTE. We screened it for focus groups and also our Patient Family Advisory Council. And more importantly, we made changes based on what that group feedback was. Again, they spoke and we listened. Slide, please. these are some of the patients that were actually telling their stories. And as you can see, we have a very diverse group. Amaris up in the left-hand corner is 24 years old. Susan had a blood clot after surgery. And these were the patients that were actually telling their stories. We have over 285,000 views on YouTube at this point in time. Slide, please. So in evaluating this education bundle, we're looking at the three aspects. So in interaction with the provider, we have our paper form, and then we have our video form. Slide, please. And if you would like to read more on the impact of this bundle, you can look here on the on this hematology article. Slide, please. So when you're looking at that education bundled studied methods, it was a real-time missed dose alert that was built into our electronic health record system, which alerted staff that a dose had been missed. Again, as I had said before, is in real time. So we have potential to impact that dose and not have subsequent doses missed. Slide, please. That patient engagement bundle included that one-on-one or face-to-face engagement with a nurse educator initially. In doing these multiple face-to-face interactions, we were actually able to develop scripting. So as we deployed this to other units and to other venues, is we had that scripting of what we found was more effective. So things like, how do we keep you safe in the hospital? Other things such as risk. I don't want to hear about everybody else's risk. I want to hear about my risk. So that's how we're trying to engage our patients. And then we've talked about the 2-page patient education sheet, and then also our 10-minute video. Bundled together, we found that this was most effective. So I'm going to turn it back over to Elliott, and he's going to talk about the results.
Great. So thanks, Dauryne. Excuse me. So now we took that bundle and we did a study on it. We did a high quality intervention study. It's a before after study, but we had a control group. And this is now old, it's 5 years old. We looked at data on 16 adult nursing units at our hospital. We did the intervention. And when I say we, Dauryne was the face of this project. Dauryne did the vast majority of all these interventions. We did 2 medical floors and 2 surgical floors, and we had 12 control floors where nothing changed. We didn't do the intervention to try to improve these missed doses on those floors. We used them as our control floors to look at the data. So what does this look like? Here is the finding from the study. This is the main overall finding from this paper we published in JAMA Network Open. And I'm going to walk you through it. So the way this works is we have our intervention and control floors looked at separately, and we've got the pre versus post. So in the on the control floors, no change, 13.6 to 13.3, no statistical change, and the odds ratio is basically 1, no change. But if you look at the column for the intervention from the pre to the post, you'll see this dramatic drop, basically almost a 50% drop in missed doses on those floors where basically Dauryne did the intervention. Dauryne went as the person giving the one-on-one discussion, and then Dauryne handed them, here's a piece of paper, maybe English, maybe Spanish, maybe Arabic, whatever it is, and here's an iPad, watch this video. That's the bundle intervention, and it works. This is the data on the any missed doses. This is the data on refused doses. It's basically the same. No change on the control floors, dramatic, nearly 50% drop in refused doses on the floors where the intervention happened. This is what the visual abstract looks like. It just shows you all together, missed doses dropped. And like I tell people, the elevator speech is 50% reduction. Not exactly, it didn't quite make 50%, but nearly 50% reduction. As a side note, we thought it was really important to make sure that we examined for any potential healthcare disparity as well. So Dauryne told you we had variety in the patients and representation of different patients in the video. We thought that was an important piece as well. So it's good to know when we look at it, there is no differential effect by race. This intervention doesn't work better for white patients or better for Black patients. it is the same size of effect size. It works in all those different populations, and the effect size is basically the same. And then the same question, male and female, similar effect size, almost exactly the same, about a 50% drop, no matter if you look by race or by sex. And we think it's really important to make sure we're not worsening disparities we know already exist. So, the overall is, wow, we worked for a long time. We did all that work. We asked patients what they wanted. We created the bundle. We did an intervention and it worked. And the effect size is huge. Great. That was 4 floors. Tell me more. So the answer is we got a little bit more money from PCORI and scaled this up to one of our community hospitals across the entire hospital and across all the floors at Johns Hopkins Hospital where this is applicable. And what does that data look like? Very similar effect size. So this paper we just published a few months ago, this is the patient intervention across 16 floors at Johns Hopkins Hospital. Similar, nearly a 50% reduction in missed doses on all of those floors. Same kind of thing, large effect size. What about at our community hospital? And this is, a couple 100-bed community hospital, same issue. Whether you look at it, this is on one specific floor, it's the first paper we wrote, similar effect size, 50% reduction in missed doses with this intervention bundle. Well, you might ask, what about the entire hospital? Each one of these lines is one of the floors at Howard County Hospital. And you can see the before versus after. And in the before, there's all these squiggles that are all over the map. Some floors are up in the 20% missed doses, 18, 15%. And then as time goes on, after that intervention, look how quickly it drops. It drops and it sustains. It makes a difference across this whole entire hospital. We've done it at now 2 places. We have more data on other places as well. So now we're scaling this up even further. So like I mentioned before, I'm a trauma surgeon. I worked with a group called CLOT, the consortium of leaders in the study of traumatic thromboembolism, and we got more funding to do this and spread this out even further. This is being done through CENTER, the Coalition for National Trauma Research, of which the AC Forum is now an affiliated member. So we got together with all these different stakeholder organizations. Some are patient safety in general, some are CLOT organizations, some are trauma organizations. And you'll see on here Society of Trauma Nurses. This is not just trauma surgeons telling trauma surgeons what to do. This is this multidisciplinary approach. We've got a multi-center study going on all across the country. There's all the little dots. And what Dauryne was talking about is we have these implementation materials. We showed you the paper education tool for the patient, but we also have these educational materials for the nurses. They go do the online education. We take these posters, we hang them up at the hospital in the break room or in their education room or the conference room or wherever. The bottom 2 things are badge cards. We've seen people carry them around. You punch the hole in the top and you hand it out and you put it on the badge card, and it reminds the nurses of the terminology to use. Dauryne's done this intervention hundreds and hundreds, if not thousands of times, but the average nurse on the average floor isn't going to do it that often. So they can remind themselves of what to do. What do I do when a patient misses a dose? Here's what I'm supposed to do. And then this bottom one to the right, we printed out postcard size, hand it to a patient. They can use a QR code reader and go right to the video, watch it on their phone, their laptop, their iPad. We also have it on our electronic, Epic MyChart tablet by the bedside. You can go to the handout. You can go to the handout in English, in Chinese, etc. It's all available right there. They can share it with their families. So the materials are ready. We're willing to give any of these away for free. If you want them, contact me, contact Dauryne. We can get you any of this stuff that you'd like to use at your hospital. Here's what this badge or this postcard looks like. So we talked about this recently. CENTER hosted us on the consensus conference to implement optimal VTE prophylaxis and trauma. If you're interested in that material, you can go there. You can watch. Access to the whole entire 2-day conference was recorded. All the slides are available. You can go watch it for free on the CENTER website. Thank you to the NIH for funding this conference. And the reason I actually put it up here is the patient. So we've said it a few times, and I'm just going to reiterate how important the patient is. So this is a photo we took at the conference. It was a small niche conference. It was hybrid. These were the people that were there in person. For those people who've been working on thrombosis for a long time, Bill Gertz is in the back. He led it off with my 30 years on working on VT prophylaxis and trauma. And the reason I show this picture, this is Leslie Lake. Some of you probably know Leslie. She is a leader at the National Blood Clot Alliance, and she came to give the patient perspective. And she tells her personal story of her PE, how she found it, and how she didn't feel as though she was listened to and heard and empowered as a patient. So bringing that story to all these other people that are researchers, doctors, nurses, PhDs, pharmacists, et cetera, we think is really, really important. Changing practice is a team effort. I usually end my talks, if I'm giving it by myself, by saying, I'm the one here presenting on behalf of Johns Hopkins, but today it's me and Dauryne. Dauryne and I are presenting on behalf of Johns Hopkins, but we've got a big team. I already showed you our picture with the Surgeon General visiting. We've got a symposium we put on every single year, for past, 14 years. That's a picture from another couple of these. And the top right picture, you'll see us standing around and then 4 people sitting at that table. Those 4 people are patients. They come and tell the patient story at our symposium. They are important to be at the table just like we are as clinicians and as researchers. When I give this talk in person, I ask everyone in the audience to, hey, who's been to a breast cancer walk? And like half the audience raises their hand. I say, okay, put them down. Now I say, who's been to a blood clot walk? And it's literally usually just me, right? This is us at a local fundraising event sponsored by NBCA years and years ago. I dragged my kids out there. It's me in the sweatshirt. It's Dauryne in the back, out with the patients. This is an important piece, we think. So for more information, these are some of these websites. These will be shared later with all the other materials. And I just wanted to say, on behalf of Johns Hopkins Medicine, for me and Dauryne, thank you very much for allowing us to speak today.
Well, thank you, Elliott. Thank you, Dauryne. This is really important information for our audience to hear, to see. And what really struck me during the conversation is how there was really this 3-tiered situation of, education of providers, education of staff providing the care to the patients, and then education to the patient. So you didn't leave anyone out. And I really appreciate the time that you spent sharing with us the patient's perspective and, really ensuring that you get the patient's buy-in, because ultimately it's for naught if the patient doesn't want to receive the medication or doesn't have the education or the information that they need to understand the importance of the medication. So yeah, thank you so much, Elliott. Thank you, Dauryne. We're going to start our question and answer portion of this presentation, which is actually our favorite portion of it. Dauryne, if you want to pop up your camera, we'll get started here. There she is. Awesome. Okay, so I'll lead off with the first question. As a nurse, my thoughts on this, we're going back to in the ICU, the patients, you're discussing with them, I'm going to give you this shot and it's going to prevent you from getting blood clots. But, this the injectable nature of low molecular weight heparin or unfractionated heparin is a big barrier. And so, when nurses are administering these medications and patient refuses, it's interesting to find out why the patient refused or why the medication was not administered. Was it a timing issue? Like you mentioned, giving it in the middle of the night, if you don't want to wake up your patient to give them a shot, is it timing issue? What is the barrier? Does the patient not want to receive it? So in your research, when a patient refused or the dose was not administered, did the nurse free text into a box, or was there like a pick list of why the medication was refused or not administered? Just be curious to hear a little bit more about that to benefit our audience.
Me, Elliott?
Dauryne, that's 100% you. Dauryne knows this
100%
data
me.
backwards and forwards.
So we didn't actually collect that granular of data for every single patient, but some of the experiences I've had were, some patients just didn't want it. One of the goals that we had, again, was not to bully a patient into taking a shot, but to make sure that they were getting the best prophylaxis they're willing to take. Some of the examples of things that prevented them, they had bruises, they had knots, there was pain, there was fear of needles. One patient, I walked in, he was 19 years old, and I had the needle and the 25 gauge in my hand, and he looked at it and he said, "That's all that's big. That's just he had seen nurses using a 19 gauge needle to drop meds and thought that's what he was going to be stuck with." So that miscommunication sometimes is just enough to enable a patient to make a better decision for them. Utilizing some of the aspects of side effects is, using that terminology. We have to talk about side effects for HCAPS questions. Is what better medication to do that with than heparin? Because you have bruising, but there's things that we can do to help that. Whether patients, may react better to icing it down before you administer it, making sure they know it. There is some quantitative data that it hurts less. That's always hard, to capture, is pain and bruising. But some of these things enabled patients to make, and I'm not going to say a better decision, but maybe a more effective decision to help keep them safe.
And the only other thing I'm going to add on top of that is a lot of times patients just didn't know. The doctors had never explained it to them. If you're in the hospital getting your chemotherapy, you had a big, long discussion with your doctor about what you're going to get and which medication and all these other things. And then the nurse comes in with this medicine the doctor's never mentioned. So we've definitely heard that piece. And to your question about data, is every single electronic medical record system is different. Some have, and we have a drop down, patient off the floor is an option, or duplicate order, or some of these other things. And there's specific interventions you can do for that. You can change. The nurses know how to change the timing from 4 a.m. to 6 a.m. They're allowed to do that. They should know that when the patient comes back 2 hours later, they can still give the dose within the medication policy. And Dauryne would educate to those other things. It's hard to aggregate the data across all these health systems as we're looking at all these trauma centers across the country. Every Epic installation has a different drop-down menu. So it's hard to aggregate them, but we would see some, I think, crazy stuff. Sorry, patient NPO. You're like, I don't know what to do with that.
Definitely. And, I think allowing your nurses to work with the timing, if you can group it into a timing where you're administering other medications, that's going to be a lot more favorable with your administration than if you're administering it middle of the night, or if it's time for, 2 a.m., that's just not going to work. So I'll toss it over to Arthur. I'm sure you've got a question to ask, Arthur.
Yeah, sure. Thank you. And excellent presentations and really interesting nursing perspectives. Thanks so much for sharing. When we think about the options for VTE prophylaxis, even over the courses of the studies that you've presented and over your 15 years or so of working in this field, we've gone from, TID heparin, BID to TID heparin to BID or QDAY, low molecular weight heparin, and now to options approved for orthopedic surgery and the medically ill that are oral. And so the questions that I have are, and we have some questions that are coming in about this, is there a difference that you've noted in compliance? And I think that, I think common sense would say you're more likely to be compliant with a once a day oral option as opposed to a TID sub-Q option. So do you have any kind of hard data on how that has progressed, or the difference in, refused doses or compliance, or even hard outcomes between those options?
Sure. I mean, and I think I'll take that one if it's okay with you, Dauryne. When I was an intern on the orthopedic surgery service, there was one option for VTE prophylaxis after a hip and knee replacement, and it was Coumadin. And you could use Coumadin, just a dose, or you give them one big dose and you give them this low dose. There's a few different things, but that's all we had 25 years ago. And now, I mean, the options are really, really interesting. Orthopedics, nobody knows exactly what we should be doing, right? You might be an aspirin person, or a DOAC person, or an injectable person, or low molecular, et cetera. So I think the data is out there on what is okay and what's FDA approved. as a surgeon, there's no FDA approved stuff for an oral option for the stuff I do in trauma or general abdominal surgery, et cetera. People are looking at it, but there's nothing FDA approved. So I'm just being clear on that piece. But your question is great. We do have data on the number of injections per day. So when we looked at missed doses and refusal, patients who are ordered 3 times a day unfractionated heparin miss more doses than patients who get once a day or twice a day low molecular weight heparin. And it's intuitive, it would make sense, but there is hard data that now supports that. So we're in the process now of changing our preferred regimen from you can choose 3 times a day heparin or enoxaparin 40 milligrams once a day for the medically ill patient or the surgical patients. The data on most of those are relatively equivalent. Okay, we're not going to review it, but just assuming those are medically relatively equivalent, it used to be that one was way cheaper. But now, with the fact that it costs time and energy for the nurses to go in and give these meds too, we are in the process of changing to a preferred agent being once a day low molecular weight heparin. The cost difference is relatively negligible. And if you consider the patient preference benefit and the nursing time benefit, it is probably the right medication to use in my opinion.
And I think what you point out is really important, is that these decisions have been made about kind of what's cheaper without consideration, as happens in medicine, right? You have these silos, you have drug costs, but nobody's thinking about outcomes of not taking a TID therapy.
100%. It's the cost, because you think of the cost of something you can write a check for, as opposed to the cost of the time, the outcomes, nursing time, these drugs, it might be $1 cheaper per day, but man, it takes a nurse 10 minutes each time they give a dose and check the med and barcode the med and talk to the patient and prep this, et cetera, et cetera, et cetera. So like, if you look at it all together as a package, I think my personal opinion is the once a day for injectable stuff is the way to go. The question about do people miss fewer oral dose anticoagulation doses, hard to tell. I would absolutely guess yes, but I don't have, trial data to show you that.
Sure. And as I hand it back over to Andrea for the next question, rapid fire question, which you showed us some screenshots of your order sets. Are you on Cerner or Epic or something else?
So that's old screenshot data from before we switched to Epic. We are now on Epic. I'm not allowed to actually share Epic screenshots. They get very upset if they're, even though we've built it within our Epic. I could talk you through it if you're an Epic site, et cetera. And we can tell you now, I am able to share Epic information of how we built this thing in Epic at Johns Hopkins with these other Epic sites that are in this multi-center intervention study. So I can send them all the code. It's not pure plug and play, but I can send them, the SQL server code to be able to build an electronic alert, tell them where it goes, and pull out the data.
Sure.
Wonderful, wonderful, wonderful. So, in the chat, I'm looking at all the questions that are coming through, and people are so interested in this and in the work that Johns Hopkins has done. And I'd be curious, if people are wanting to take first steps in their institution, what would you suggest as some first steps? Where do people even get started? Especially with this 3-tiered, you've got your provider, you've got your staff, you've got your patient to educate. Where do people even get started? It seems like a lot to bite off.
Sure, I'll take that if you don't mind, Dauryne, about the overall, and then you can talk about the nursing part. I think the first thing to do is pull together an important multidisciplinary team. If you're a pharmacist listening to this thing and you're like, oh, I heard this great presentation and we should do this, you need to find the people who care. And you need to find, a couple doctors, a couple nurses, a couple pharmacists. You need someone who's going to represent IT, because IT is going to be an important part. If you've got a quality department, find a person who can do that. So the first thing I would say is pull together your multidisciplinary team, because you can't do it alone. I mean, it's not just, me talking about this. Dauryne and I are here giving the webinar together. So I think first part is pull together the team. And then I would say, get some data. What is your problem? Is your main problem we're doing a bad prescription job? Or if you have no idea on your missed dose data, Get those Epic people or EHR people pulling some data for you. Maybe your hospital is already better. Maybe you've got a small 5% missed dose rate, and that's not worth a ton of intervention. I will tell you, as I talk to places around the country, that's not the case. But until you know the data, I don't think you can know what you want to work on. And then once you've picked a small piece, don't reinvent the wheel. Don't say, we should have a committee that makes some patient education materials. We've done that for you. You can have all of the patient education materials for free. You can go to the website today and download it in English, large print English, and these 15 other languages. You don't have to do that or do anything about it. It's vetted, ready to go. Patients love it. You want to say, we think video is important? Great. Take our video. Here's the link. Send them to YouTube. They can watch it. So now, instead of spending hours, we spent, just imagine how long it took us to do all this stuff. Don't reinvent the wheel. Just take it. It's free. Please use it. Use it for patients. So those materials are ready to go. Don't do extra work. Then you can decide where you want to focus. Dauryne, what else you want to add?
I think just in regards to, barriers at the nursing level is to make sure that you're messaging it appropriately, is we're not increasing the work of a nurse at the bedside, because there's a lot of misconceptions. Oh, I have to do all of this stuff. When you think about it, if I have a patient who refuses any medication, is I'm going to do an educational opportunity. What we're doing is giving them better tools and more accessible tools to be able to do that quicker. And as we've shown, is just by doing that educational opportunity is we decrease the amount of refusals we have, which in effect decreases, the amount of perceived work. We struggle at nursing and at the bedside right now with all of the issues that are going on with having enough nurses, having nurses that are engaged on that specific floor, nurses, with traveler nurses, the new nurses who are coming out with maybe not as robust of a bedside experience and are not comfortable speaking with patients, and we're trying to put the tools in their hands that will also translate over to other aspects and other medication issues, and kind of enable them to give better educational opportunities.
Absolutely wonderful. Well, thank you both for being on here. Thank you, Arthur, as well, for joining us. And now we're going to toss it back over to Liz for a little bit of a wrap up.
Thank you so much. I'd like to thank all of our speakers. This was an incredible discussion. Dr. Elliott, Haut, and Dauryne Shaffer, congratulations on this important work. And thank you so much for sharing this research and sharing the educational program with the AC Forum membership. You're making a real difference with the patient experience, and you are to be commended. And you made it through over 100 slides in the time allotted. So impressive. Thank you. And thank you also to our wonderful AC Forum board members, Andrea Van Beek and Arthur Allen. Thank you for excellent moderation. There were so many questions that were coming in, so hard to manage. As always, this webinar has been recorded and will be posted on the AC Forum website. Also, the nursing VTE prevention learning module that was discussed today is already live on the AC Forum website. It's free and it comes with free accreditation. So please, there's the website here, or you could also just go to acforum.org and find it. So please take advantage of this amazing free resource. While we have hopefully lots of nurses on the call today, I just wanted to encourage you nurses to get more involved with the AC Forum. We're always looking for fabulous nurses to join our team. Our board nomination process is currently open, so please email info@acforum.org if you would like to nominate yourself or a colleague, or just reach out that you'd like to get more involved in a committee or other aspect of AC Forum. I also want to remind everyone that our national conference is in April 2023. Please join us in person. Yay. It will be so good to see you there. And we also have extended the abstract deadline until Sunday if you want to submit an abstract. And oops, I don't know what happened there. Something, my last slide is not opening, but I just wanted to thank our corporate sponsors who support this webinar program. So thank you so much to everyone for spending their hour with us today, and enjoy the rest of the day. Thank you.